you. All right, I'm going to turn it over to Dr. Alexander.
Okay, should I share my screen?
No, I have the, oops, sorry, I have the annotation still on. I have the slides right here.
Okay. So thank you all for inviting me tonight. It's great to hear all your great ideas and talk to you guys. We're going to give a little bit of background about transition in care. Some of the issues you brought up will flow nicely into this. And then I'm hoping to kind of get through this background fairly quickly so we can have some time for discussion at the end. So, you know, as you guys often deal with, historically we transition between home, inpatient, acute and subacute care, outpatient care. And there's been much improvement in this over the past several decades, and advances continue, as you guys know. But the purpose of this talk specifically will be how we transition care of congenital or pediatric conditions into adulthood, specifically in congenital heart disease. Who provides that care, a pediatric or adult provider, where the care takes place, additional needs, resources, education, pregnancy that comes along, employment issues, insurance, with the ultimate purpose in mind in that patient develops through a healthcare system of a parent provider-led care to ultimately a patient-led healthcare experience as they reach adulthood. Other way. This is just a slide showing how we've, with groups like this, improved our care throughout the decades. Whereas we just started doing surgery in the late 1930s and 40s, and how initially, this is a 1-year survival chart. Initially, patients weren't expected to live that long with congenital heart disease. And now, if you see on the far right, even our very complex patients, we expect to live to become adults. And so that just highlights the improvement in care over the last several decades. This also points out how it's not just the simple congenital heart disease, but also the very severe and complex lesions that are becoming more and more frequent in our teenage and adult populations. So congenital heart disease, just a little bit of background. Many of you might know this, but it's the most common congenital condition you can be born with. About 1% of all births have some sort of congenital heart defect. Our first surgery was in 1938. We later developed the heart-lung machine. There's been many improvements in anesthesia, critical care, catheter-based interventions that all led to those improved outcomes, so that now over 90% of children with complex congenital heart disease are expected to survive into adulthood. There's over 1.5 million patients that are adults with congenital heart disease in the US alone. And we'll talk more about that later. Next. So with this growing population comes new responsibilities and issues to deal with. As we know, as kids grow up and develop, they ultimately developed adult issues. Life adds layers of complications to underlying complexities, such as jobs and having children, exercise, and other medical needs. And so there's more and more issues as patients reach adulthood, and who should care for these patients? Where should they be cared for? But there's good news. As these patients have kind of progressed through this, our field of adult congenital heart disease has also been maturing. So some of those highlights to briefly mention. We've had the development of dynamic patient advocacy groups, such as this one. Adult congenital heart disease program accreditation, where programs are actually accredited, and many must have a formal transition program to reach that accreditation. We've accredited a fellowship so that physicians are trained in adult congenital heart disease. Recently, the American Heart Association, American College of Cardiology came out with an updated 2018 adult congenital heart disease care guidelines that really guide a lot of the medical decisions that we make and recommendations. We now have a specific learning center for medical providers, nurses, fellows, doctors, and other fields about learning about adult congenital heart disease. There's been a large improvement in developing cardiac pregnancy centers throughout the country. The number one heart condition you can have during pregnancy is congenital heart disease. And so a lot of our patients are now getting in adulthood. What comes with that? Having children of their own. A lot of new advancements in surgery and cath-based techniques. And then also legislation that's improved the care for those with adult congenital heart disease. Ultimately, our adult congenital heart disease care, we hope to have better care, better survival, and ultimately better lives. And this chart just graphically kind of represents that. So click again. Oh, and that red line you see, those are patients cared for at centers that don't have an established adult congenital heart disease program. And press it again. And then here in the green line, you can see that survival and mortality is improved in those patients that are established in adult congenital heart disease programs. So we hope to move more and more patients through transition programs from that red line to the green line. So what is transition? That's what we're here to talk about. A movement, development, or evolution from one form, stage, or style to another. Medically, this is the intentional process of moving from a pediatric medical system to an adult one. As the American Academy of Pediatrics points out, the goal of transition in healthcare for young adults with special healthcare needs is to maximize lifelong function and potential through the provision of high-quality, developmentally appropriate healthcare services that continue uninterrupted as the individual moves from adolescent to adulthood. So this comes up a lot, the difference between transition versus transfer. Well, transition, as we're going to spend much of our time talking about, is the years-long process of education, development, preparation, whereas transfer is just the single act of shifting responsibility of patient care to an adult provider. It's a one particular kind of point in time. Okay, some facts about transition. About 30% of young adults lack a payment source for their health care, as you guys can imagine and have experienced. There's a lot of testing and medical care associated with a congenital heart defect. Over half of young adults have not successfully transferred to an adult congenital heart disease center, and so part of a transition program is we want to kind of address that. Fewer than 30% of adults with congenital heart disease are seen by appropriate specialized providers. Ultimately, this results in loss to follow-up is common, and more than a third of patients are kind of lost to care where they're not being followed up appropriately. Unfortunately, what does that lead to? Well, these lapses in care predict poor outcomes. There was one study that showed almost half of mortality involved patients that weren't under specialist care. And this happens not just in cardiology. Unfortunately, only about 45% of children with special needs will when they reach adulthood, won't have a physician familiar with their condition to take care of their problems. So that has led to the development of these formal transition programs. We ultimately try to provide comprehensive care that is coordinated and managed through a medical home. Well, what is a medical home? That's kind of the central hub of the medical care for that patient. Oftentimes that's their primary care provider, but in other instances, it may be their subspecialty provider or other aspects of a tertiary care center. Part of that is access to healthcare financing. As I mentioned, many of these patients come into adulthood, they come off their parents' insurance, or they come off Medicaid for children, and then what healthcare financing is available to them? That needs to be part of a transition program. There needs to be a big piece of what we do as adult congenital heart disease providers is educate other providers in managing the chronic conditions of our patients that are now going from a pediatric population into adult population. And there must be ongoing coordinated communication between the patients' families, pediatric and adult healthcare providers to facilitate both transition, as we talked about, as well as ultimately transfer. many elements of a transition program. There must be a transition policy in place, a written description of how you're going to do this process, how you're going to take a pediatric patient, prepare them for adult life with whatever condition they have, and then transition and transfer them into the adult world. How are you going to track and monitor those patients, and how you're doing, how the patient's doing, how the family's doing with that. A big part of that is readiness assessment. Is the patient ready to undergo? Sometimes they haven't thought about it and don't want to think about it. And so you have to assess their readiness to kind of educate and learn and go through that process. Transition planning. How are we going to get through that process? How is that patient going to prepare themselves to be kind of the general manager of their own healthcare? Ultimately, this is a big process in the transfer of care of that patient and finalizing with transfer completion, where that patient is transferred to an adult provider and assuring that process worked. So how do we do that? How is transition done? Well, a big part are kind of those first three: education, engagement, assessment. Educate the patient, the family, the providers about how that process is going, what their condition is, who their new providers are going to be, what other healthcare resources they may need. Biggest one is engagement, both from the provider, that they're engaged in the patient going through this process, but the patient and the family themselves, that they're engaged about learning about their healthcare condition and preparing for that adult life, and then assessing how that's going. And ultimately, repeat. You go through those steps over and over again until ultimately the patient is ready for what adult care will mean, and that's when they're ready for the transfer to their new adult provider. So who does this? Well, historically, and oftentimes still is the case, transition is usually done by the providers of the patient, the docs, the nurses, the staff, whether it's their pediatric or ultimately their adult providers. There has been a recent shift to adult congenital heart disease educators as the primary agent. This is a specialized provider, usually a nurse, who begins the education and assessment process with the patient. And as you see throughout society with the use of technology, there's an increasing role for things like transition tools and apps that can help supplement this transition process. Okay, so question that comes up: when do you transition? Well, there's not a specific time because it's patient specific. The timing to transition from being a kid to an adult varies widely. As I heard many of you all have adolescents, you all know that it's a big time. It's a big developmental change time, and so some patients are ready, 8, 9, 10. Some patients really aren't going to be ready till 18, 20, sometimes 25. For this process, and that's where a lot of that assessment and patient readiness comes in. But it should be started relatively early, adjusting to the patient's needs. Oftentimes, this is kind of around the time of puberty through adolescence to young adulthood, occasionally earlier. Transition is relevant to, and processes should be in place for all patients as their care needs determine, including those who may not take full responsibility of their care. So some patients that aren't going to reach that full level of I can take care, I can make all my doctor's visits and take all my medicines, but they should also be, even those patients, and especially those patients, should be included in a transition care program. Okay, so what pitfalls often come up? Well, the biggest one for me is engagement. And that can be at any level, any particular member of that, transition team. That can be the providers, both the pediatric and adult teams, as well as the healthcare systems. They need to be bought in at the importance of transition programs. Patients, obviously, they're the main player in this. They need to be engaged in going through this process, as well as the families. And as you guys know, healthcare is provided in limited episodes, while this transition and maturation process are a continuous, ongoing process. Sometimes it's an issue with resources. Some places don't have access to formal programs. We're still a little bit lacking in tools and apps and some of our monitoring tools, but those are improving. And ultimately, sometimes it's a funding issue because education, we know, provides a great benefit. It's been proven to show improvement in outcomes, but it's unfortunately poorly reimbursed. Okay, so some of the takeaways I want you guys to take away from our talk tonight is, you know, we've seen major improvements in outcomes for children with congenital heart disease. The vast majority now become adults. And so much so that adults with congenital heart disease outnumber children with congenital heart disease. That they passed them up in about mid 2000s, about 2005. As these children with congenital heart disease grow up, it's critical they learn how to navigate the medical system and care for themselves. There's a lot of ongoing heart issues and other issues that can come up related to their congenital heart disease as they progress through adulthood. Specialized care by these adult congenital heart disease programs is associated with improved outcomes. Unfortunately, many children and families do not receive appropriate education, and many never transfer care to an appropriate adult provider. That's why we're talking about this tonight, because the hope is with formal transition programs, we seek to address these issues, reaching these children and their families to ensure they have high quality care throughout their life. Obviously, we've identified and talked about many challenges to optimal transition care, and hopefully partnerships with patients and families will become one of our keys to success. So how can you guys help? Well, just as being part of this group, many of you all are already doing this, but you're advocating for adult congenital heart disease and transition programs. Engage yourselves, engage your children in these transition programs. Promote education, funding, and transition. Join groups that promote these important issues, such as PAC3. Adult Congenital Heart Association is just one example. Educate yourself and others about congenital heart disease. And ultimately, you know, when you're seeing care providers, ask about how you or your child will be transitioned and transferred. What's the plan to ensure lifelong care for a lifelong disease? Always play the long game. There's a lot of issues that we know that we've identified that can come up, and you want to know how your child or you yourself as a patient will be cared for over time. And with that, we'll open it up for discussion.
I put a question in chat, but I can read it. And sorry, my son's running around screaming. I guess I'm assuming you have to transition. That was somewhat of a, I'm curious, do you have to transition or not? Our son's 3, and we've obviously developed a very close relationship with our cardiologist. They know him very well. It's a very scary proposition to have to kind of redevelop and trust a new care provider to know everything about your child. So do you have to transition, I guess, as a first question? Second, what are the tips on obviously planning ahead and kind of coping with that stress that inevitably comes up?
Well, that's a great questions. My personal belief is yes. I think all patients should ultimately transition, because I think there's a clear benefit to seeking care as one becomes adult with providers that are familiar with adults and adult issues. I was trained in both pediatric and adult congenital heart disease. I take care of children with heart disease as well as adults. But what I can tell you is, as a child, as a neonate, you want somebody that's very specialized to know what's going on in a child or neonate. When they become 18, 25, 30, might have issues like pregnancy for a female. You want somebody that's comfortable and familiar with heart disease in pregnancy. Later on in life, there can be acquired heart disease. There can be things like diabetes, kidney disease, high blood pressure. And so you always want somebody that, I would say, that's familiar with those conditions and is kind of an expert in those conditions to have the best possible outcomes. Yes, it's a big, as a parent myself, it is a big step, because you become like family with a lot of your providers and children. But I think that's where the transition program comes in to kind of help you through that kind of initial fear of, oh no, this doctor knows us so well, to no, maybe there's a new provider that can kind of help us manage these newer issues that could come along in adulthood.
Thank you. That was great.
Dr. Opatowski, I don't know if you have additional thoughts on that.
No, I think Samir, you had mentioned that you've grown to trust someone, and it's hard to learn to trust someone else. And part of becoming an adult is realizing you should trust nobody, right? That's no, I'm just kidding. But it really is a very difficult process when a family has developed a strong relationship with a provider. I think in some ways, I don't know how to say this, but while there's that very, very strong relationship, it feels to me that sometimes it's the parents that have an even stronger relationship with the provider, because the parents probably developed that relationship during those very early, that early most intense period of care. And the child often does have a relationship and cares about the person. They obviously care a huge amount about that child, but it's often the family that has more of a challenge than the patient themselves. In a sense, that's part of the, a person growing up and developing their own relationships. And I know it's not always a better switch in terms of a doctor you trust more or whatnot. But I do think everything that Craig says is the more important aspect, and that is the issues of someone who knows the problems that come up for adults more often and understands that intersection between adult issues that are acquired over time and congenital heart disease. But in addition, it's also starting afresh in a relationship that is not dependent on the parent being the sort of the introduction and the one with the closer relationship. Me not being a pediatric cardiologist and being an adult trained cardiologist, I'd ask Craig whether he thinks that my popular psychology mumbo jumbo might be realistic and meaningful.
Definitely. I think having that perspective is very important. And you're exactly right. As a parent of a child with healthcare needs, I definitely know there's definite feelings of a parent and our connection with the provider that kind of got us over the hump and got us through some of those acute issues in childhood. And I think that's part of that ultimate transition is you're ultimately kind of passing over that process to your child as they become an adult and take responsibility for their care.
I have a question. Marie here. Is there any special considerations when you're dealing with someone with a cognitive disability such as Down syndrome and transferring their care?
Yeah, I think I was trying to kind of touch on that point a little bit, that the transition process is very patient specific and has to be very patient specific, but should include all patients. And definitely cognitive issues like patients with trisomy 21 definitely do need to be included in that discussion. And so there may be different levels of, well, how much is that patient going to call and make their own appointments or be responsible for taking their medications? Some of those may be perfect for one patient, but another patient may be unable to do all of that. And so you've got to take each patient kind of patient by patient specific and direct kind of your goals of transition of care specifically to that patient. Whereas, one patient may have a list of 100 things you kind of want them to achieve, taking their medicines, making their appointments, meeting their primary care physician, what employment opportunities they're going to have. Some other patients may not have quite as long of a list, but it's still important that you kind of go through and make some goals, because there are still, regardless of kind of the abilities of each patient, there are definite changes to their care as they reach adulthood, and other adult issues that will come up that need to be prepared for.
Thanks, Craig.
Excellent question.
I have a question for you, Craig. Could you speak to the transition in surgical care in addition to just a more general cardiology care? Is that something to also consider as our children get older? And, you know, there are some of us who know that further surgeries might be necessary down the road as they become more of an adult body. What does
Yeah.
that look like from your end?
Yeah, so I'll answer that the best way I can if I think I'm getting the gist of your question right. So to me, there's kind of two aspects. There's the surgical needs from a congenital heart disease standpoint. And from that perspective, you still want a surgeon that's most familiar with congenital heart disease. So actually, there's been studies that generally show if surgery needs to be done on the heart, it's best done with a surgeon that's familiar with congenital heart disease. So it may actually still be the same surgeon that did the neonatal repair that's doing a surgery in their 30s or 40s. Not always, but oftentimes it is. Because that's who's most familiar and going to know the intricacies of the heart and what needs to be done, as well as what's been done before. Because that's important in kind of planning a surgery going forward. So that's why I think a lot of adult congenital heart programs, even if they're located in an adult healthcare setting, are still tied in with a congenital heart program like a pediatric heart center. Because of that need for some of that familiarity and knowledge. Probably the other one that I think about as a adult congenital heart doctor is surgery for other issues, not the heart, because sometimes surgery can be done on a patient with congenital heart disease for a hernia or a lung mass or a brain, you know, whatever it may be, but there could be a big effect for both anesthesia risk as well as what needs to be done in and around the surgery, aftercare, and that sort of thing. And I think that sometimes takes some specialized planning, because sometimes a pediatric surgeon may not be the best surgeon for, you know, your gallbladder removal or you know, whatever other adult surgery you need, but there needs to be some coordination of care with some knowledge of the congenital heart disease, because there's going to be special both medical care and anesthesia care around that surgery pertinent to the congenital heart lesion. And so that comes up a lot. And I think that's a big part of why patients in an established adult congenital heart disease program tend to do better, because there's that collaboration and that planning process around procedures for other issues.
Thank you so much.
And I think actually I mean, everything Craig said is absolutely right on. And I think to bring the last two questions together, one of the times that comes up most often is people with additional developmental cognitive delays often benefit not as much from the cardiac care from pediatric cardiologists, but rather the other care in a pediatric institution. Dental care being very commonly more challenging at adult institutions and adult dental care. And so often a pediatric institution will have adult congenital providers and be willing to provide some of those care services later in life, knowing that it's better for the patient, even though they might have an adult cardiologist, an adult primary care doctor, or something else of the sort. And so part of our job is actually a little bit of care coordination and thinking what's best for the patient as an adult congenital provider. Having just moved here a year and a half ago, I will say that I think that is universal no matter where you are, and that trying to find the right place for each patient for each situation is always a challenge and something that really does provide real benefit independent of cardiac issues.